So as any disease, what is more important is the stage of the disease at the onset of treatment. So currently when we find the patients by the clinical manifestations, we lose the opportunity of this very valuable time before the patient gets sick, and while he or she is in the minimally symptomatic or asymptomatic stage, but with a known prognosis. So newborn screening will give us the opportunity to identify these infants before they become symptomatic. Most infants, I'll say, because some of the disorders, unfortunately, like Gaucher disease type 2, will have a presentation at birth and sometimes actually prior to birth in the pregnancy period. And then we will understand the whole spectrum of the disease process, why some individuals are staying asymptomatic or minimally symptomatic, so these are the milder patients, whereas a similar genotype will cause a more severe presentation in another individual. So this is one aspect to understand fully the natural history of disease before the patients get sick. And second is for the conditions and for the genotypes when we know that there is a certain prognosis, like the L44P homozygosity for obviously it is associated with neuronopathic Gaucher disease. It may have minimally symptomatic, but actually majority of patients will have the full-blown neuronopathic symptoms. So will give us an opportunity to consider treatment before they really get symptomatic, because otherwise, you know, we usually get these patients around 8-9 months of age or to a year, and they are quite sick. They have spleens that are probably 10 times enlarged, with, you know, growth issues and low platelets. So there is a process to revert them to the normal physiology. And unfortunately, some of them will never recover, as opposed to infants that get treated very early on before they get sick. We get actually quite a bit of results that are contrary to the patient when they get sick, with better outcomes for early management. So obviously neonatal screening in lysosomal disorders in an arduous process. The reason is the neonatal screening is basically a risk assessment, I said, so we'll understand the confirmatory diagnosis, what it entails, and what is the progression of the disease. But also it needs to require an established therapy which is shown to be effective in the patients. So there are multiple therapies that are coming on right now, as we actually hear in this meeting. There are candidate gene therapies, small molecules, so on and so forth, for various disorders. So as they continue developing, we will be understanding the natural history of various disorders, and as the patients are getting ready to be treated with these novel therapeutic options. So basically it is a state's decision, and even though it doesn't cost too much, obviously there needs to be some certain criteria. So basically so I'm going to take back to Gaucher disease. This big discussion is whether we're going to be catching the patients with type 2, where there is not a current treatment option, even though there are studies you know, working on it. And then the type 1 patients who may remain asymptomatic. Okay, so basically we have this similar dilemma, I think, for every disorder. And it requires actually first a consortium to vote for the disease, which actually needs to have an early infantile or neonatal presentation. There needs to be an asymptomatic stage or minimally symptomatic stage, and there needs to be treatment options available. So not all the disorders actually fulfill this criteria to be candidate for RUSP. I mean, one of the big examples was Pompe disease, and it took honestly years for infantile Pompe disease to be on the RUSP program. So it depends on the state's decision and whether this is a vision for them, and not every state actually will screen for the disorders even on the RUSP. The focus of the panel, actually, we want to introduce the RDS concept of newborn screening and introduction of newborn screening to lysosomal disorders. So we're going to start from the very beginning. What is recommended uniform screening panel and what does it entail to be included in that, and what is the process after the inclusion, meaning setting the diagnostic criteria and having management guidelines. So as we move forward, the second speaker will talk about the technology that is currently being used, multiple techniques using like mass spectroscopy or genomic techniques for not only the screening process, but also for the confirmatory process, including the biomarkers. And our third speaker will focus on the management. So when they have a screening result, how they walk through the path for the confirmatory process, and also the management and, if necessary, treatment of these infants. And the last but not the least, we have a patient advocate who is very interested in the newborn screening as the numbers. So when we gather all this information, apart from treating the infants that require treatment at that time, what do we do with the big data? So how this huge data that is going to be accumulated over the years will be used for different purposes. So our GRIS Symposium actually is fledgling, and we are very proud because it became with the virtual hybrid in-person formatting. Actually, we are able to reach masses over the world, so we are very proud. We had attendees literally from Tibet, India, UK, Germany, and Africa. So basically the first thing is to inform the interested healthcare professionals or any professional that is actually interested in lysosomal disorders to be acquainted with that. So to provide equity, not only the ones that are lucky enough to be in this country to get exposed to various knowledge. This is the first one. And the second aim of this it is a small format symposium, so it is not a big one. It is on purpose. The reason is we want the attendees and also the speakers to mingle with each other. So we kind of try to do in a free format. I mean, obviously there are topics, but we try to leave the discussion as long as it entails. So there are questions raised and the answers are discussed and the collaborations are made. And through this actually symposium, I know that there are many projects that are formed through multiple groups and multiple countries. And the third thing is what we want to achieve here. Obviously, we are interested in the novelties, and that happen every year, but we want to focus on a subject. Like this year's focus will be on the epigenetics and epigenomics. And we want to get the experts in the field who may not be in the lysosomal field, like in the engineering field. We want to actually invite a colleague and a friend of mine who has been working on the nanotechnology, and they develop a nanotechnology on COVID antibody testing. And the question is whether we can apply this technique to antibody testing in lysosomal disorders. So these individuals do not necessarily have the chance to meet with each other, to work with each other, or even to interact with each other. So we want to achieve this as well. And through this symposium, actually what we did is we work with the engineering department of Penn State University. So we established actually a 3D model for the Gaucher disease as far as the bone pathology is involved. So we were able to demonstrate that there is a developmental issue to start with in the bone involvement in Gaucher disease. So this could have never been achieved if we weren't if we did not invite the individuals in the engineering department and also discuss what Gaucher disease is. We taught them about the biology of lysosomal disorders. So this actually brought up a model which could be used for drug screening or even can be customized to each patient for individualized treatment protocols. The LDRTC is a freestanding unit that is specialized in lysosomal disorders, but also we have interest in other rare disorders. So it is one of a kind, unique in the world. I think that my colleagues after the establishment started similar institutes in Germany and Canada, akin. So what we do is, our main aim is to bring the most recent advances in the disease, both the understanding pathology and the treatments to the patients. So the reason is rare disorders are challenging for both the patients to access to therapies and also the physician to be able to understand disease pathology by seeing a number of those patients. So this LDRTC will marry all of these, actually have established that. So we follow actually about 500 patients with different lysosomal storage diseases. And then we provide treatment protocols. So we ran about 44 to 50 protocols so far, and currently there are probably 30 active protocols that entails gene therapy, small molecule therapies, next generation enzyme replacement therapies, and with the history that we started is a little bit around 10 years now, give and take. So we brought several products to the market, and then we are not only proud with our work, but we are enabling the patients to get access to these novel therapies much before that they are on the market. And the other thing which is unique about our institution is obviously we are a free enterprise, meaning we are not affiliated with an academic center. It doesn't mean that we don't do academic work. We have many publications. We have a translational lab. We just actually acquired a GC mass spec machine so we can actually do our biomarkers. But we have the ease of starting a new protocol through scratch and getting to the start of the study in a very short time. So we actually overcame the hurdles of bureaucracy that exists elsewhere. So the other thing is we are also able to work with the several advocacy organizations. So we have a recent project with one of them that we if they have an interest for a biomarker discovery or a started treatment protocol, it's within our interest and ability that we can write the protocol from scratch. That's what I did. We discuss with the FDA, we get the IND, in this case, we imported the medication, and then we are running the early, the introductory phase, which is the understanding natural history of the disease, and we're going to start the treatment protocol. So basically, we can start from the very beginning of a protocol and then get to the treatment phase within our ability.